Welcome to this clip on basic medical ethics. So these are ethical principles you would want to be conversant with when you come to the medical practice. So the ethical principles that guide the practice of medicine. So the first principle here is truthfulness and confidentiality. So a medical professional, especially a doctor, is expected to be truthful at all times and to manage information between him or her and his or her clients with utmost confidentiality. So whatever is communicated, of course, to the patient should always be the truth. It should also always be correct. So a clinician should not be pressured to twist the facts. There are times when you find some requests, you could find a scenario where maybe a woman with cancer, and then the son wants the doctor to twist the facts, so that you can hold back some information from the woman. Yeah, of course, sometimes you could find that some of these requests may have some good intentions behind them, but they trample on the principles behind our practice. So in this particular station, you see a woman who has cancer. She's old, she is weak, and she has had cancer before, but it was treated and she was in remission for about 5 years. So at this particular time, the cancer had resurfaced, and it had also metastasized to various parts of the body, various organs of the body. So the CT scan was out and the woman is diagnosed again with a metastatic form of the same cancer. So the son here would come to the doctor and say, "Doctor, please, can you maybe hold back this information? Don't tell my mother that she has cancer." So, of course, it sounds very real. It sounds very good intention, well intended, of course, but it challenges the basic principles behind the ethics that guide our practice as doctors. So the doctor should not allow him or herself to be pressured to twist the facts. Of course, there are safe ways of informing the same woman. Yeah, those are skills that the clinician must always have. But of course, it should not change, our truthfulness. I should not divulge information, of course, except permission has been given to do so. Every patient's information should be treated with utmost confidentiality, only with their permission. Should it be shared with a third party, except, of course, in certain circumstances, and we're going to look at those times when you need to break confidentiality. So you may find a station where there's a surgeon who actually works in the same hospital, a very senior surgeon, and then the mother was admitted in the same hospital, and she has just been diagnosed with cancer. So the woman has not been informed. The results of the CT scan is out, and of course, it shows that there are metastatic lesions. Now, this consultant comes up to the junior doctor and wants the junior doctor to, to divulge the information. What exactly is wrong with my mother? So at such times, there is that challenge for the doctor to say, okay, he's my colleague, but of course he's not in the same team. So should I share this information with my colleague without the permission of my mother? Ethical issues there. So being a colleague is not enough. If one is not in the managing team, he or she has no direct right, except by referral, except the person's professional input is needed. But you should not divulge information without permission from the patient. Now, the second principle we'll look at is the principle of autonomy. Okay, autonomy basically tells us that the patient has the final decision on his or her care. Okay, so the doctor may know what is best for the patient, but the patient still owns that right to decide if he or she wants the care to be given or not. So whether they take what is recommended or they decide to do something against what was, of course, is recommended by the professionals, you should always respect such decisions. You may not agree with them, but of course, you should respect them. You find patients who sign forms, for do not attempt resuscitation or do not attempt cardiopulmonary resuscitation. And you may have needs or have maybe some professional reasons why you want to counsel against that. You may also find people who opt for abortion, in pregnancy, and you may have moral, you may have religious reasons why you do not believe in abortion and things like that. But of course, so long as it's within the ambits of the law, so long as it's within their rights, and so long as within what is the scope of the practice, within where you are, you must respect the wishes of the patient. So if the public is at risk, we may reconsider this autonomy. For an instance, in public health outbreaks, conditions that may put others at risk, of course, we may reconsider, some of the scope of the autonomy principle. We're going to look at it in details shortly. Now, you find the third principle here, the principle of beneficence. That means that every decision the clinician takes must be in the best interest of the patient. It must be in the best interest of the patient. Okay, so the interest of the doctor and, of course, the preferences in terms of options of care of the doctor might be wonderful, might be professionally inclined and professionally informed, but it should always be in the best interest of the patient. Okay, so always attempt to do that. Okay, put the patient's concerns, identify them, and put the concerns of the patient, at the fore of formulating a management plan. So it must meet their needs. And of course, for a doctor to do that, it must be found in the consultation to explore the concerns of the patient and, of course, to carry them out while formulating a management plan. The next principle here is the principle of nonmorphism. This principle basically tells us to do no harm to the patient, whether it's intentional, whether it is inadvertent. You should attempt always not to do harm to the patient. Not to do harm to the patient. Do no harm at all times. Okay, so where you find that you are restricted either by reason of resources or by reason of expertise, by reason of even the guidelines that, of course, tells what should or should not be done in certain places at certain times, you should refer or escalate to seniors if need be. So let's say a patient comes to the GP surgery, and of course this person needs to be admitted, or this person needs to be given a care that is beyond primary, that's not supposed to be offered at primary level. So what do? You should refer the patient to the appropriate specialty, send the patient to the hospital. Of course, if let's say, even in the GP surgery, let's say it is a care that can be given at that level, but it's a care that you cannot give as a junior doctor, what do? You should refer or escalate it to your seniors. Call your seniors and let them know there is an unresolved issue here. There is something that I think somebody senior should take a look at and, of course, give professional opinion. We also have the principle of justice. The principle of justice. Now, this tells us that all resources that are available, should be distributed equitably. Okay, should be distributed equitably. Preferences should not be given to anyone, whether by reason of gender, by reason of profession, by reason of race, by reason of social class, or by whatever reason. Okay, so all available resources must be distributed equitably. Okay, there must be a criteria that does not discriminate or puts some sets of people above others. So all patients must be treated with equal rights, irrespective of their financial or social status. They must all have equal access to the resources they need to improve their health. It just has to be so. Now, there are some specific considerations when it comes to ethics. Now, the basic principles we have looked at, we can put them, reshuffle them into these specific considerations: capacity, consent, confidentiality, And under confidentiality, of course, we'll talk a bit about breaching confidentiality, and then we'll look at confidentiality in minors, looking at the Gillick and Fraser criteria, and then we also just take a look at the specific considerations on medical ethics when it comes to children. Now, there are a few other issues here as well. Okay, we need to know at all times who is involved. It's good to identify who exactly you are dealing with when you want to apply particular ethics to clinical scenarios. Is it the patient you're talking to, or is it a relative? Maybe the mom, the dad, the uncle, the son, the daughter. You want to find out who exactly am I dealing with. So it gives room for you to know, of course, what particular ethical principle you want to be careful about. Let's give for an instance. You're talking to a patient. Of course, autonomy should be at the fore of your dealings. But if you're talking to a relative, the very first principle you want to be very careful about from the onset of your interaction is the principle of confidentiality. Okay, is the confidentiality. You want to be sure that even from the onset, before we start having a discussion, that this person has legal clearance to know about this particular patient or to even take decisions about the person's clinical condition. Okay, so you must also identify their viewpoints. What do they think? Do not forget that if you must practice beneficence and of course tailor your practice towards the best interest of your patients, you must know what their interests are, you must know what their concerns are, and of course you must carry that along. What do they think about the condition? What are they worried about? These are common questions that a clinician must be seen asking in a clinical consultation scenario. What do you think about this? What are you worried about particularly? And these must be carried along. You must identify the key issue in the clinical scenario. Let's say you find a patient who has come with a particular condition. It could be a medical condition, but the key issue in that consultation could be something social, something emotional. Now, all through, the doctor is expected as well to negotiate solutions and to summarize. Formulating a management plan should not be a prescription. It's not something the clinician must, say, write down for the patient to just do, tell the patient to just do, inform the patient what must be done, or enforce it on the patient. Absolutely not. Okay, so of course, international best practices for clinical consultations, there must be a negotiation of solutions. So what this means is that if the doctor has identified the medical issue in this particular situation, but the patient has some social, some emotional, some family, some religious concerns, and then both of them can bring their concerns and of course the medical aspect together, and of course negotiate together on how we can, make progress irrespective of maybe varying positions or some sort of discomfort in certain areas. I'll give you an example. You have a doctor who has identified a patient with a chest infection and he knows this patient needs antibiotics. But the patient does not want to stay in the hospital to receive the IV antibiotics because his granddaughter has a birthday within 1 or 2 days. So they must find a common ground between helping the patient meet up with this very important engagement which he or she feels he cannot do without. And then the doctor also has an interest on the IV antibiotics. So there must be a negotiation of solutions. What are the alternatives? Are there alternatives that can help these two come to an agreement, have both interests carried out, of course, and making some progress? So you must negotiate solutions. Can we give the antibiotics at home? Okay. Is there any chance that can be done? Okay. Can we start the antibiotics and on the day of the birthday, maybe you go for the birthday and come back? Of course, it's something that both must negotiate and summarize. And of course, if there are issues that are not resolved, let's say for the scenario I just gave, that somehow we couldn't find the common ground, then of course if you should escalate it to somebody who is senior, who maybe has more experience and then can take up the conversation and find a common ground for all parties involved. Let's look at the issue of capacity. Capacity basically has to do with ability to decide. Okay, one's ability to take a decision. If they have that ability, then they have capacity. Now, capacity is at the very, it's at the very basics of the principle of autonomy. If a patient has capacity, then we can respect his or her autonomy. If the patient does not have capacity, then we know that their autonomy maybe will have to will it to somebody else or consider other alternatives to respect their wishes. Okay, want to find out, did they leave wishes before now, or did they authorize somebody else to take decisions for them? So capacity is very important, and for certain clinical scenarios, we must assess the capacity of the patient to take decisions. And what are the components of capacity? How do we say this patient has capacity and the other patient does not? Now, a patient is said to have capacity if they have a good understanding of their clinical condition. If, let's say, okay, they have an understanding of why they came to the hospital, what the doctor has said, all of these symptoms and signs put together mean, they must have an understanding of that. And that means they should be able to, receive the diagnosis and have a clear understanding of the explanation. And they should also be able to retain it. That means if asked later, they should be able to have stored that information and can reproduce it. They should be able to process what the doctor has said, and then they should be able to, based on all of that, communicate a decision. So let's say this man came with chest, let's say this patient came with cough and came with fever, and of course all the other things that could happen within that scenario. And then the doctor has said that based on our interaction and based on my examination and maybe even based on additional tests that were done in the hospital, I think you have a chest infection. So Mr. A, who is the patient, should be able to, if asked, of course, maybe a few hours later or whenever, if asked about why are you in the hospital, you should be able to tell us that he came with cough, he came with fever, and the doctor examined him, and the doctor did some tests, and then the doctor said he has a chest infection called pneumonia. So that means he understood, he retained what the doctor had said. He has, he should now be able to process that information and now say, I know he said I need antibiotics, but I do not want. So he understood, he retained, he's able to process it into a decision, and he can communicate that decision to the clinician. So if a patient can go through these 4 stages, four important stages of assessing capacity, then we say this man has capacity, this woman has capacity, and we can respect their wishes because they are autonomous. Now let's look at more about capacity. Now, when do you assess capacity? Do you do it in all situations? Not really. So if, let's say, a patient who came with a clinical scenario, in a clinical scenario, a particular condition has been diagnosed, and then we recommend, for an instance, that this patient should be admitted and given so and so care, and then the patient is refusing admission, you want to find out. Refusing appropriate treatment, okay, is one reason why we should check if this person is refusing from an angle of information. Is this person stable enough? Should we respect the wishes of refusal because the person knows what he or she is doing? So you want to assess capacity. You want to know if the person has understanding. You also assess capacity if, let's say, there's something in the particular scenario, when the patient came, that maybe suggests to you there's loss of capacity. Let's say, for an instance, the patient is confused. Okay, so even without refusing admission or refusing any other appropriate treatment, you can see that confusion in itself affects mentation. confusion in itself affects, it possibly affects understanding. So you want to be sure, does this person in this confused state, does he have an understanding of why he or she came, what we have done, what we have recommended, and can the person reproduce it to us and give us a decision? So you also do that in minors as well. So minors on their own, of course, it's assumed that up till a particular age that the minors may not be able to take an informed decision for themselves. But we're going to look at that in a little more details. Now, if we, after assessing people that fall into this category, and we find that there is capacity, even if they reject what is in their best interest, if they reject the care that the clinician is putting forth as what could help them recover or at least manage their clinical condition, then of course we have to respect their wishes, but we must promote their best interest. We must let them know what we think would have been best for them. And of course, if they still say no, you do what? You respect their wishes. If they do not have capacity, sadly, you have to seek consent from a relative who has been given advanced authority to give consent. So there may have been some paperwork that had been done to say, if by any chance, by reason of health, by reason of whatever else, I am not able to take a decision for myself, okay, so let my daughter be the person that can give consent for me. But if by any chance there is nobody, okay, to do that, or the person who has that authority is not accessible, is not reachable, then the consultant in that particular unit, will take up that responsibility to sign the consent form for whatever is in the best interest of that patient. Now, when you want to assess capacity, what information do you provide to the patient? Now, for the patient to have an understanding, it means you must have provided some information, which of course, the patient will understand and be able to retain, be able to process and reproduce to you. So what information should you provide? Number one, information about their condition. What have they come with? What is your diagnosis? And you must make it, as a clinician, you must put it in simple terms so that language, expression, technicality will not be a hindrance to the understanding. Then you must also make it clear what the treatment plans are and, of course, what the options for treatment are and what you have recommended. You must also explain to them the benefit of the treatment. This is why I recommend this, or this is why we have so and so and so treatment options for this condition. Okay, then you of course must tell them about the risks associated with the treatment, possible complications, and maybe any side effects of some medications in the treatment plan. So it must be holistic information: the condition, the treatment plans, the one you recommend, the benefit of that treatment, any downsides to it, any risk of certain complications or certain side effects. And then you must also let them know what happens if by any chance they refuse these treatment options. And of course, if there are other treatment options, maybe you presented 3 things and they are rejecting the first one. They are rejecting the one you think is best for them. Then you might also want to suggest alternatives to them. So this gives a whole, it gives a panoramic view of what the clinical situation is. And of course, the clinician must have done a wonderful job doing this. Now, in minors usually are people less than 16 years, you have what we call the Gillick competence. Now, what this means is that a minor can have a good understanding of, what we look at when we assess capacity. So if a minor understands the components that we mentioned earlier about capacity and is able to retain it, is able to process it, is able to provide a feedback on decision, then we can allow that particular minor to take that decision. We can say that minor is Gillick competent. But the law on Gillick competence, or this legal guideline on Gillick competence, only allows them to consent for treatment and not to refuse treatment. Now, this is what it means. This means that, let's say we have advised a patient who has features of acute appendicitis to have a surgery. And this child is 15 years, for an instance. And maybe the parents refuse, that they do not want a scar on the tummy of this beautiful young girl. And then the girl is in the room, she's hearing all the conversations, and she says, no, but this thing will kill me, you know. And then we'll say, okay, mommy or daddy, can you excuse us for just a second? Let's just have a word with Angela. And then we talk with Angela and we provide all the information we provide when you want to assess capacity. Now, this is what you came in with. This is what the diagnosis is. These are the treatment options. And we think to remove the appendix at this point will be the best option. And we have to do that through a surgery. Okay, it could be a laparoscopy, it could be a laparotomy, no problem. But these are the options, and this is our best interest. This is our best option. And then she says, okay, I understand what you have mentioned. I understand the condition that you have diagnosed. I understand this. I understand all you have said. And she's able to reproduce all of that. And she says, I think you can go ahead. I give consent to go ahead. We are going to take the decision of this 15-year-old girl because she is consenting for treatment and not refusing treatment. Now, if we reverse the scenario, I will say the parents are saying, why not go ahead with the surgery? And then the young girl is saying, I understand everything and I am refusing because I do not want a scar. Now, she is a minor. She has capacity in terms of the steps in capacity, but being a minor, Gillick competence will not be respected here. Why? Because she is using Gillick competence to refuse treatment. So if a minor refuses appropriate treatment, it is not counted as Gillick competence. Okay, it shows that the minor does not have insight into what is in his or her best interest. Now, also, minors have a right to confidentiality. Okay, so a minor comes to clinic and the minor says, I want contraception for this and that. You must not share that information with the parents, except with the express permission of that minor. So they have a right to confidentiality. Now let's look at consent. Now there are two types of consent. Verbal consent, you find that in, mainly in many normal consultations in clinic. Of course, you want to take a history from a patient. Of course, usually you find that I would like to, you find a doctor as maybe saying something like, okay, how may I help you? Say I have fever or I have cough. Okay, so would you like for me to understand what could be going on? Would that be okay if I ask you a few questions? So right there is taking a verbal consent. Would that be okay with you? Will it be all right if I just check a few things to find out what could be wrong? Or let's say you are finished taking history and then you want to examine and you now say, okay, so I have a little insight based on our interaction. Of course, in the history taken, based on our interaction, I have an insight into what could be wrong. But of course, I want to do a few examinations. I want to, maybe examine your chest, listen to your chest, listen to your heart. I want to check your blood pressure. I want to do this. I want to do that. Okay, so to help me understand a little more, about what could be wrong. Would that be all right with you? Will that be all right with you? That is seeking consent. So it's verbal, mainly in consultations. Clinicians should and do take consent. But when it comes to procedures, let's say I want to do a camera test for you, for us to take a look at your bowel and see if there are any abnormal areas. Okay, so in which case, we might also take a sample of some tissue from any area that looks suspicious and send for an investigation or a test where it may help us understand if something is going wrong. Now, usually after saying that and the patient agrees, before procedures usually will do what we call written consent. So mostly you see verbal consent in consultations, and then you see written consent mainly in procedures. Now, come to confidentiality. This means that patient's information must be protected. Now, when you say you are keeping a patient's information in confidentiality, it does not mean keeping to yourself as an individual. It means keeping it within the health team. Now, what this means is a junior doctor sees a patient, and then he says, of course, I'm going to treat all we have talked about in high level of confidentiality and all of that. But it does not mean he cannot discuss that consultation with his seniors. Okay, so long as the information is within that particular health team, of course, the principle of confidentiality is still in place. So when do we breach confidentiality? There are certain situations where we may have to breach confidentiality. For an instance, in notifiable diseases. Let's say you have a woman who serves food to people, and then she comes to the clinic and she's diagnosed with viral hepatitis A. Because of her job that puts other people at risk, if she, with this condition, goes to serve other people food, it might result into a viral hepatitis A outbreak in the community. So it is a notifiable disease. You must inform the occupational health department. In cases like abortion, for an instance, okay, there are organizations that check abortion regulations within the UK and, of course, in many other countries. Okay, the British Pregnancy Advisory Service does this in the UK. So for them to, of course, be sure that ethical principles are followed in the abortion proceedings and all of that, then they need to know what happens regarding abortion across clinics. So, of course, it is the responsibility of different facilities that may offer this service to, of course, give feedback in terms of statistics and maybe a little more, of course, to help keep things in check. Same thing with organ transplants. Their bodies responsible, be search warrant from a court, okay, in which case, let's give for an instance that a court of competent jurisdiction requests that a doctor, maybe comes to the court to present a medical report on certain issues that has, been tendered before the court. Then the doctor has to, of course, present that report with or without the consent of the patient. So in this case, the doctor, the clinician, is summoned by law, and that will not be illegally breaching confidentiality. In this case, you have to ethically breach confidentiality. Okay, so vital statistics from birth and deaths are usually volunteered to the Department for Vital Statistics. It is not illegal breaching of confidentiality. In vitro fertilization as well, there are ethical bodies that review how it is done within the UK and in many other countries as well. So when you find yourself in these particular scenarios, you can breach confidentiality and it is not ethical. Now, you must note that confidentiality in the examples given are breached to organizations, not to individuals. Okay, you're not breaching confidentiality to your brother or your sister who works in British Pregnancy Advisory Service. That is breaching confidentiality illegally. So you are only breaching the confidentiality, or you are providing this information to the organization officially. So in each case that you have to breach confidentiality, even if required by law, it is ethical for us to always inform the patient when and why you have to do this. Okay, so Mrs. James, because of this condition called viral hepatitis A, I am actually required by law to do what? To inform the occupational health department. So this is because of your job of serving food in so and so place, other people who patronize that particular place stand at risk of contracting this condition or this infection from you. So the occupational health department will need this information to take a little bit of more precautions to protect the public. Now, you can also breach confidentiality in certain conditions, like, transient ischemic attack, or even a stroke, an outright stroke. Okay, in transient ischemic attack, if a patient, continues to drive after you have advised them to stop driving for a while, and then let's say during follow-up you find out that they have continued to drive. So it is your duty to inform the driving and vehicular licensing agency about this development. This is because they would need to withdraw the license of the particular patient to keep the public, in safety. So the same with food. If you find food poisoning, tuberculosis, or meningitis, of course, you need to inform the public health department. While seeing pediatric patients, you find non-accidental injury, or you find this even in geriatric patients, you want to inform the social services. In children, they will, of course, the child protection services under the social services will do an assessment of the situation and take relevant action. The same with domestic violence. Social services may have to be called in, but that is only if children are involved. If it is domestic violence between a man and a woman, adults themselves and their children are not involved, it is a social issue that the police can be called in. Of course, that is their choice if they want to involve the police or the social services. But as a clinician, only if children are involved would you want to call the social services and involve them yourself. Now, special considerations when it comes to children. Okay, so in IV drug use or in domestic violence, just like I just explained, if there are children involved, you must call the social services to assess and be sure that those children are safe. Children themselves can give consent, of course, but they cannot reject appropriate treatment, just like we mentioned earlier. So parents can consent or reject treatment for their children, but the children can only give consent for but cannot reject appropriate treatment. But their parents can do both. The decision of parents can be challenged if it is found by the clinician to possibly bring harm to the child. So let's say, for an instance, that you can see that this patient will need blood transfusion. And maybe without this, the child may not survive the health situation. And then the parents, are saying that no, for whatever reason, that they do not want blood transfusion. The clinician can challenge their autonomy, can challenge their authority to take decisions for that child. So in cases where you do not have, a responsible parent or guardian or anybody at all to take a decision for that child, the consultant takes over that decision-making process and, of course, gives what is in the best interest of the child. Now, Mental Capacity Act of 2005 was actually drafted to, to help people with, some kind of mental capacity issues, to appoint decision makers ahead of losing ability to decide. Let's say in old people who by any chance, as they age, maybe by region of what we call senile dementia or vascular dementia, maybe they have repeated cardiovascular accidents, and of course they are beginning to have issues with their memory and things like that. Or even without any clinical issues, but they just want to appoint somebody in case something undesired happens. So this Mental Capacity Act states exactly, how decision makers can be chosen ahead of losing ability to decide. Now, this act allows the appointment of 3 cadres, but of course, the clinician is only interested in 1. Now, appointment of lasting or enduring power of attorney is an appointment of someone who has the ability to take medical decisions for of course, a patient who has lost capacity to take a decision at that time. The appointment of a deputy and the independent mental capacity advocates do not involve a medical component. So a lasting or enduring power of attorney can take medical decisions for a patient who has lost capacity. So note that at any time, these appointments can be reviewed, so long as the patient has capacity or either lost capacity initially and has regained the capacity, they can review these appointments. Now let's talk about professionalism. The doctor, of course, is expected to be professional at all times, and this means that he or she should do things appropriately. Okay, must interact with patients with very good interpersonal skills and should be properly dressed, should be honest at all times, of course, should always say the truth, and of course, have appropriate behavior. So doctors have a professional, legal, and moral obligation to their parents. They have professional, legal, and moral obligation to their patients. Now, what does this mean? If the doctor violates a professional obligation, of course, the regulatory body, like in the UK, the General Medical Council, may, of course, withdraw their license to practice. So this means, of course, that maybe in interacting with the patient, maybe putting the patient at risk or making the patient undergo a particular harm or whatever else that looks like that, all within the professional conduct, the person may lose his or her license. Now, there are legal issues as well. Let's say, for an instance, that a clinician is found stealing, for an instance. Okay, that is a legal issue that the police may come in. It has nothing directly to do with the professional conduct of the person. And of course, whatever is applicable to whoever else that is or is not a doctor in such circumstances will apply to the doctor here. So let's say there's a jail term for armed robbery, or there's a jail term for forgery, there's a jail term for abusing somebody in public, assaults and things like that, murders, So of course the doctor would have to face the appropriate legal penalty for that misconduct. Now, in such legal situations, the General Medical Council may also consider it a professional misconduct, and in line with the legal punishment, might also add a professional penalty. Now, the doctor has moral obligations to his or her patients. Now, if by any chance you violate these moral obligations, okay, it may affect the relationship with the patient. Let's say, for an instance, moral obligations here includes accommodating or at least respecting sexual orientations, race, and religions of the patient. And of course, if by any chance that the doctor puts his or her preferences, his or her inclinations above the patient, and of course spoils the relationship between him or her patient, that could be the penalty in that case. So of course you find a couple of patients who come to the hospital and they say, I do not want to see so and so doctor. So of course they have, because they have failed the patient morally, in terms of their moral obligations, they lose the relationship they have with the patient. Now, when do you say no to a patient or their relatives? When do you say no? There are times when we may, of course, hear certain consents, hear certain requests from certain patients, and then we'll just have to say no. When do you say no? Of course, when there is no consent from the patients to divulge their information. So if a patient has not given consent for us to discuss their clinical situation with their husband, with their wife, with their brother, with their sister, with their father, with their mother, with their children, with their whatever relatives, if there's no consent for you to go ahead and discuss what is going on, then you should politely say no to that relative. You can also say no when the patient has expressly said don't. The first time is the patient did not say anything. So of course, you can't go ahead. Then the patient might also specifically say, do not discuss this with my relative. Do not involve my relatives. Of course, you must politely say no. Now, if there are professional, legal, or moral issues around that particular situation, let's say for an instance, a patient's relative or even the patient is him or herself wants you to lie, wants you to change what the clinical information is, then it will of course bring up the issues of professional misconduct. Let's say that a patient or a patient relative brings up the issue of helping me to kill my relative. Of course, help me give the person something lethal. So that, of course, raises up some professional issues. Of course, the ethical principle of do no harm comes into play. And of course, there are legal issues there as well, because it could be interpreted by the law as manslaughter, and of course, anything that looks like it. So if there are professional, legal, or moral issues that come up, you can politely say no. Now, if an individual or the public is at risk, you can say no as well. Okay, if someone is being put at risk by reason of this, maybe a particular setting, a particular scenario, a particular situation, you can politely say no. The public must always be protected. Other individuals who may be related directly or indirectly to the patient or to that particular issue must also be put to